Good morning.
Okay, well let's get started. Welcome everyone. Any public questions, Julie?
No, no questions.
Okay, any apologies?
Apologies for lateness from Tamina.
Oh, yeah.
And Rebecca's also hoping to join the meeting, but she's travelling at the moment, so she may not be able to.
Yeah. Okay, yes, that's thanks very much. Declarations of any other business? Declarations of interest? Minutes of the meeting of the 9th of July, any corrections?
Sorry, Minu's got his hand up.
I apologize. Sorry, Minu.
Sorry to interrupt. I thought it would be appropriate to declare a new conflict of interest. It's already on the register, but since the 1st of September, I have started as non-executive director at Royal Berkshire Foundation Trust. So just wanted that noted. Thank you.
Thank you very much, Minu. Okay, so corrections to the minutes. Action log and matters arising. I couldn't see anything that wasn't already in hand. Okay, quality section 6, board story, community health inpatients. Debbie, do you want to do the introductions?
Yes, sure. I'm glad you both joined. I thought I was going to be doing it myself for a minute. So we've got our ward manager from Jubilee Ward and our lead for inpatients here today, who are really keen to come and do a patient journey story from our inpatient ward, community inpatient wards, which we haven't heard from for a long time. I will let them introduce themselves and take over the presentation.
Good morning, everybody. As Debbie said, I'm Caroline Edwards. I'm the lead for community inpatients. I'm here in support of Sagal, our wonderful Jubilee Ward manager. She's running the show, so I'm going to let her introduce herself.
Hello, good morning, everyone. My name is Sagal, and as Caroline has said, I'm the ward manager at Jubilee Ward. And thank you all for giving me the opportunity to share our patient's story.
Pleasure.
Okay.
Yeah, we can all see it. Well, I can anyway.
Thank you. So I'm going to first start off by giving a bit of background information. So the patient was admitted to Wexham Park Hospital after a fall and sustained a left humerus fracture. So he was born deaf and communicated using British Sign Language. He had progressing dementia and his daughter was the carer. A long acute admission of 56 days and he lived alone prior to the admission. He was admitted on the 8th of February for rehabilitation. So the acute referral to InReach. So he was referred as a pathway 2. So when patients are usually referred for community rehabilitation wards, they're referred on 2 pathways. So a pathway 1 is a step down when all the patient's assessments have been completed and all the appropriate referrals have been done. So our patient was referred as a pathway 2, which is for rehabilitation. So we needed to complete his assessment and complete a safe discharge. We had a morning admission to facilitate the daughter being present. So they were both extremely anxious and this was really important for us to accommodate. So it was a weekend admission also. Things we planned before the admission. So we contacted Remark Interpreting Services to book sessions. And I completed an informative handover to all the staff about the admission. We printed out a large food menu and informed therapy team and doctors of the times the BSL interpreter was booked. We completed a communication pack and a communication board and made sure that all the communication aids were easily accessible for the patient. Things we did during the admission. So we completed a PEEP, a personal fire evacuation plan due to the fire risk on the unit, booking interpreter in advance for important interventions using Remark. regular updates from the multidisciplinary team, and this was really important for the family. So there had to be really good communication. We enabled flexible visiting times for the daughter, and this was prior to the Trust's update on visiting times. A communication needs preference form was completed, and a communication needs care plan, which we regularly updated. Therapy engagement. So the patient attended strength and balance groups, well-being groups, and the daughter was invited to several joint therapy sessions. The patient enjoyed attending the group therapy sessions because within the community, he was very social and he attended a deaf group. So this was really important for him, and we wanted to make sure that he had this on the ward also. So the next slide looks at the Aging Well outcome. So the Aging Well outcome is a tool that we use to assess patients' mobility, transfer, and it gives a holistic view on the patient's ability and community reintegration. And this is usually scored out of 67. So on arrival, our patient's score was 16, and on discharge, it was 34. So he attended 36 therapy sessions, and there was one session that he declined to attend. Discharge planning. So discharge was complex, and the reason that it was complex was due to the patient's communication needs and cognitive impairment. He was not really able to understand what the best discharge destination was for him. A mental capacity assessment was completed, which showed that he lacked capacity. So then after this, a best interest meeting was held with an interpreter and the daughter. And then it was at this time that it was decided that the best destination would be a residential care home for him. So we communicated these options with both the patient and the daughter, and we sort of let them take the lead so that they were able to find the most suitable residential care home for him. Onward referrals. So the patient was referred to the memory clinic, an anticoagulation review for his pulmonary embolism, community physiotherapy, and the daughter was referred to a carer support group within the community. And she was also referred to the Living Well program post his discharge. Patient's experience. So the patient felt listened to and included in all aspects of his care. Feedback we received from the daughter was that the patient received excellent care, and we got a lovely written card at the end of the admission. We bridged the interpreting sessions for him for 3 days to help the patient settle into his new care home. And the reason we did this was because the local authority could not get the funding in place for a BSL interpreter on discharge. So we bridged this gap and funded for 3 days to help the patient settle in. And the next slide I just wanted to share the card that we got from the patient with you. And this was really lovely to receive. And our main goal was to provide the best care for the patient that we could. And we did that. And that he was able to communicate and engage with patients and other staff. So this experience or this admission provided the ward with a really good learning experience. And prior to the admission, we did not have much knowledge on how to best support deaf patients. Thank you all for your time. Any questions?
Gal, thank you very much. Could you share the screen just so we can? Okay. Is it not possible to unshare the screen, Sagar?
Sorry, I've done that.
Okay, that's lovely. Thanks very much. Just so we can see everyone better now. Thanks so much, Sally.
Really interesting patient stories, Sagal. Do you have any reflections on being a very senior nurse that we have this patient with sort of cognitive decline, and yet he went all through, you know, prior to us he was in acute setting, then us, and presumably during that time he lacked capacity, and then we discovered that at the end. Do you think there's any reflection on that?
Yes, I think there is some reflection that we could do on this, and maybe we should have done the mental capacity assessment earlier on his admission. But we knew that he had a progressing dementia, so we were aware of his cognitive impairments. But maybe that's something to take back.
Yeah, I'm also thinking in his previous experience too, when he was, you know, obviously you were acting in his, I'm sure, you know, in his best interest. But I find that quite interesting that it was sort of done at the end. But very, very interesting. And you clearly went out of your ways, you know, with his challenges around communication. Thank you.
Sally, I just to come in, Sally, we would always do a best interest assessment on the situation, so we wouldn't at the beginning of a hospital stay, when we didn't know where the outcome was going to be, do a best interest assessment to understand his understanding of his long-term placement. We would always do that nearer to the point of making that decision with him, if that makes sense, because mental capacity is a situation and a point in time, not a generic not a generic thing, if that makes sense.
It does. And I'm assuming there would have been some handover also from his, you know, in terms of where he was in terms of capacity. Thank you.
That's Caroline.
Hi there. I think Sigal's underplayed a little bit the preparation that she did prior to this gentleman coming. So this gentleman was identified by our InReach team, who obviously the referral was made by the acute, and the InReach matron had done a lot of work to understand the patient's needs prior to us coming, and it wasn't as simple as him turning up on the ward and figuring it out. The InReach team and Sigal, I was in the meeting, and the meeting, Sigal suggested a meeting so that we could discuss and make sure everything was in place to support the patient before he came, which I think helped a lot of the anxiety for the daughter. And I don't think she's underplayed her part in that. The communication that she had with the ward was something I've never seen before. You know, this gentleman was very well prepared. The medics prepared, the therapy teams prepared, and it was a very, very smooth transition. And it was a really good example of that team working, the InReach team, the Flow team, and the ward team. It was really, really great to see. And she's mentioned that the daughter visited the therapy session, but the daughter was very emotional when she got to join the therapy sessions, to see her dad be very engaged and active and having a lot of fun. And you know, the therapy team did a fantastic job, as they always do with this gentleman.
Thanks, Caroline. Sigal, can I just ask, I always know when I visit Jubilee Ward what fantastic care you and your colleagues give patients. I'm just wondering if, thinking about the wider sort of relationships between acutes, ourselves, and the local authorities, etc., this has clearly been exemplar of how to do it right. But are there sort of things you think, if only we could fix this problem, it'd be so much easier for us, and either the way we get patients in or the way we discharge patients, or is it, are you happy that everything is sort of working fine?
I believe that everything is working really well. We have, as Caroline mentioned, we have really good, communication between our teams. The InReach team are really excellent in prepping the ward for the admission. And, you know, the therapy teams, the medics, the nurses, I believe what we're doing currently works really well. It works, so there wouldn't need to be any changes.
That's lovely. Well, Caroline.
Sorry, I just thought I'd add to that. Definitely in terms of internally, you know, the bringing the patients in, but I think, you know, the flow role and the communication that we have with the local authority now, I think is greatly improved. Those complex discharges, and this gentleman was a complex discharge. You know, we wanted to make sure that he was he was able to continue his progress, and it wasn't just he finished with us and then it stopped. Hence the interpreter. You know, we liaise with the local authority very well because we've got those relationships now. And this is certainly a story that I think, now that we're all one big happy family, east to west, we've shared with the West teams, and there's certainly learning that they've taken from that as well, should they have a patient with similar needs.
Excellent. That's really good news. Okay, well, in which case, could I just thank you both and say, Al, thank you again, and please pass on our thanks to your team, because I know they're an excellent team and doing a great job. So thank you very much for all you're doing, and thank you, Caroline, for your contribution. And we'll let you get on. Thank you very much indeed.
Thank you. Have a nice day, everybody.
Very much. Bye.
Take care. Bye.
Well, that was a lovely presentation, Deb. Thanks so much for that. That's I must say, Jubilee Ward staff there are lovely. I think whenever I go, and it's great.
They were really keen. They were really keen. They really wanted to share this story with the board. They were really keen too. So
it's very impressive, isn't it? The way Sagal has got all this. I don't know if it's just Sagal, but got all these factors together and it all joined up, and it's quite a complex set of issues, aren't there, to manage.
They're very complex, and then with the interaction with the family, you know, the daughter in particular. Yeah,
fantastic. Oh, well, it's good we got people like that around. Okay, we'll move on then, please, to 6.1, the patient experience report. Debs.
So this is our usual quarterly report. I think the two things I'd probably pull out as detailed in the highlight report are, we have seen quite a positive shift in our 5-star rating for our mental health inpatient wards, and it's not because we've had a drop in the numbers of responses. In fact, we've had an increase, so that's really positive to see. And we have restarted our 15 steps visits, which are actually valued by everybody. Great contribution from non-execs, governors, and people with lived experience, and the staff and the services really do value those. So it's really good to see that we've actually done quite a few this quarter and restarted that as planned. And other than that, I'm happy to take any questions.
Thanks so much, as always, Deb. Any questions? No, all looks very clear. I think you got off easily today, Deb. Okay, so that includes the complaints. You can do that separately, or Deb?
Yeah. So it includes the complaints, which are obviously detailed in here. There's nothing unusual to talk about in respect of that.
Okay.
Deb, can I just ask you one question? Sorry, Martin. As a non-exec, when I look at the data, do you know, I'm never quite sure whether you can benchmark it. Do you know what you look at the numbers as a non-exec and you think, well, is that good or bad, or it's that I sometimes struggle with. Perhaps that's just me. I'm assuming you can't really get benchmarking information around complaints. You know, what would be the normal amount of complaints, and is it good or is it bad?
So we have a relatively low number of complaints per 100,000 population, but it is quite tricky because different services tend to generate different sorts of complaints. So it's not actually that easy to say, well, we've got more or less than you know, raw barks or whatever. But Model Hospital does do an element of benchmarking but it is very raw data. It is literally just how many complaints you get per 100,000 population. And the saying, you can't really necessarily compare apples with apples depending on, you know, what sort of services you're providing.
I'm assuming you've just got to take it and look at what it was before, you know, what the trend is, and then triangulate it with other information about that area. You know, you sort of, your antennae goes up and you think, oh, well, you know, we also had this. But I do find it quite sort of, when I look at these, I think, is that good? Is it bad?
I mean, the important thing for me is, you know, things like how many PHSO complaints we get, for example, because that is where people have not felt we've managed to resolve their concerns. So they're then writing to the PHSO, and then whether they are upheld or not, which we get, very few of. We've had one in that I'm showing this quarter. That's the first one for over a year. So things like that, and whether we manage to resolve people's concerns internally, I think is probably as important, because again, probably half of our complaints are not found. So
yes,
again, it's really difficult when you're just doing a raw data comparison.
Yeah, definitely. No, that's really helpful. It gives me, I'll look at that as well in terms of resolution. Thank you very much.
Thanks, Deb. Naomi.
Yeah, just real quick, Debbie, on the feedback piece. Do we know of any other trusts that use the I Want Great Care tool?
Yes, but they don't. They all use it slightly differently.
Yeah.
So Oxford Health use I Want Great Care. They don't use it in quite the same way as us across to be able to benchmark all of their services in quite the same way, but they do. So when we designed it with them, we designed it how we wanted it. But yes, there are quite a number of trusts that use I Want Great Care.
Yeah, my thinking around it was specifically given the heavy lifting that we've had to do to raise the number of responses, and I know that's still ongoing, and I know I'm very well aware of the efforts that are being made there across each of the teams. Whether or not there's any experiences around that from other trusts, particularly within our ICBs, who might have some insights. I guess they're all finding it tough, right?
We are not an outlier in any way, shape or form. We probably get more feedback than some trusts.
Gotcha.
And a lot of trusts. We certainly are not, not in the, many trusts don't even have a mechanism of this kind to collate it in this way. So no, there isn't any magic. Magic. No, absolutely.
Thank you.
Thanks, Deb. I just listened to Sally's comments, and I recognise that it is very difficult sometimes to benchmark these things, and we don't want a huge industry of benchmarking. But it might be worth just sort of thinking, offline about whether there are some of the parameters, the complaints or the ones going to the ombudsman or whatever, as a sort of a subset of important type issues to do with patient experience that we might be able to find a way of getting a meaningful benchmark. I not do the whole lot, but just if there's something, because I'm with Sally in terms of the general issue, which is as a non-exec, you always worry, is this, have we got a comparison? Are we miles adrift, or are we sucked into a very local short-term type of statistics rather than standing back? I'm not implying there's anything to do with that here, but it's just a sort of whether you can just think about in slow time if there is a subset or something that could just bring that comparison, sort of benchmark and comparison in a meaningful and simple way. But perhaps I'll just leave that with you, Deb.
I'm not sure that is ready available. Things like PHSO say what we can get on Model Hospital is complaints per 100,000, but it's a year behind. The data isn't like it. So how meaningful that is probably up for debate, to be honest with you, because I'd be reporting last year's when we've already signed off and sorted. But I'll see what I will have a look and see if there's anything that would enable us to have give you some kind of indicator where we are.
And maybe just discussion within the Quality Assurance Committee might be the way to do it, and so a multitude of questions, as it were, and then that can report back to the board. Maybe that's the easier way of doing it. Okay, Deb, thanks very much indeed. Quality Assurance Committee.
I think that the board should be alerted to the progress in relation to the patient safety, the National Patient Safety Alert pertaining to medical beds, trolleys, bed rails, and bed grab handles. We've talked about this before, and what the board received was a sort of update on the actions in relation to that. There were 7 actions to be completed by the 1st of March 2024. But I think Debbie will keep me on the straight and narrow, but there are 2 of those actions that relate to equipment that we have prescribed to be used in the community. And there's an outstanding issue of community patients that have been prescribed these bed rails. I think that have still to be assessed, but it's a regional, national issue, and there is good oversight in relation to that. In relation to the quality concerns report, it's good news that community nursing and eating disorders have been removed. I mean, community nursing has still got its challenge, but there's good grip there and oversight. And what we've got is a new concern that's been added, which is around the community-based neuro rehab, and it's essentially the waiting list times for assessment and treatment due to demand exceeding capacity. What I would draw the board's attention to is actually, which I think is really innovative, the application of Martha's Law, and Martha's Law was well publicised nationally. It was on the news a lot around the child that died at King's, and the parents sought a second opinion, and they weren't listened to. And I think what's interesting about this is that Martha's Law, in its current format, is perhaps more focused on the acute hospitals, and it was the acute hospitals that were asked to respond initially. But what we've done here is an attempt to apply Martha's Law within the context of mental health and community trust. At the moment, for all sorts of logistical reasons, it's being piloted almost, or proof of concept, at Prospect Park. The community wards will be slightly more challenging, but I gather from Debbie and Minu that the Health Innovation Hub is very interested in this, and I think it is quite an interesting development. And you'll also see, and I'll mention it to the board because again it's a very high profile issue, is the Sexual Safety Charter, which was issued to trust. I think, Debbie, it was issued around about, I don't know, earlier this summer, and this is the application of our response to the Sexual Safety Charter. There's 10 principles, we comply with 6, and there are 4 outstanding. But I'll stop there, and if anybody would like to raise anything around the board. I've said something incorrect, Debbie. I can see your hand going up.
No, it wasn't incorrect at all, Sally. I just thought it was worth sort of clarifying around the CAS alerts to do with the bed rails. The challenge we've got, and many organisations have got, is where patients have been on our services for a very short period of time. They've been prescribed equipment and then they have not needed to be on our services anymore, but the equipment might need to be long term. So they may well be having services from local authority, through agencies, etc. So it's how we coordinate that within systems to ensure that people get those assessments when they are no longer open to our services. And because it goes into the thousands of patients, anybody that is still on our caseloads, we are absolutely working through doing those assessments, and we are working with local authority, the ICB, and this is being taken up regionally as well and nationally. What do we do around those patients that have a long-term piece of a bed rail or a bed stick to help them long term, but are not open to any services? Who will be doing those assessments? That's the gap.
Thanks, Deb. Okay, Minu, could you just say a bit about learning from deaths? And
thank you, Martin. Yes, it is a standard report. I have included a section on ethnicity after your request at the last board meeting.
Thank you.
Every time I look at the data at the moment, because we have a very small number of deaths and virtually none which raise a concern for the governance concern of avoidability, there isn't any interpretation we can do from this, but we will continue to keep an eye on this to see if there is any suggestion of any differential outcomes for different ethnic groups in the trust. Otherwise, it is an exhaustive information, data in every way that we can demonstrate that we do a very detailed and thorough analysis of all deaths in this trust.
Thank you very much. Any questions on that? Yeah, Guardians of Safe Working. Oh, Julian.
Yes, just thought it would be worth referencing, Martin, yesterday, the Essex inquiry into the deaths of the Essex Trust. Essex was 2 trusts, and in fact, actually the third was involved as well. The London Trust was involved, and that's obviously been put onto a statutory footing. There's quite a lot of attention sort of given to that, and likely to be some sort of lessons which I guess many will be keeping an eye on to see. You know, I know this has been stress tested in a number of ways through such inquiries, but there's probably always things that will come up in terms of sort of the concern the inquiry reveals. And just wondered, you know, what's your take on that, and how we'll stay abreast of what's going to be quite a lengthy process by the sounds of it.
Absolutely, Julian, thanks. I mean, apart from the standard media information, unless we get some national directive interim during the inquiry, we will just continue to keep an eye on our system. I think it's important to note that even we started our mortality analysis learning from deaths absolutely at the outset of the recommendation, even before the national directive came to us in 2016-17. And we have kept on improving on it. I don't think we would ever be in a position of weakness, at least within the current system, saying I don't mean there is no room for improvement. But of course, if there are any recommendations, we will pick those up and add those to the current assurance that we are providing.
Thank you. Thank Julian for raising it. Guardians of Safe Working report, Miriam.
There is nothing of concern there. We've got 3 exception reports. If you recollect, there was 1 month when we had a spike of 17. We did some quite detailed work with the Guardian, with the consultants on the inpatient wards where this mostly occurred, with some of the training mechanisms, and of course with our junior doctors who are now known as resident doctors. And we are back to just 3 exception reports for very valid reasons. But we continue to keep the work going on to ensure that our doctors feel that they can raise an exception report at any point, and that our consultants respond to those quite swiftly to make improvements. So nothing of concern there, but happy to take any questions.
Okay. Any questions on that? And then just the one thing Sally, I slipped over was your modified terms of reference, and whether
yes.
the board is content or not. Did you want to say anything about them?
No, the terms of reference clearly add that we received the Mental Health Act report and the annual place of safety report, which we have been receiving. It's they've just gone into the terms of reference now, and we've added in the membership, which I perhaps should have said, is that we've added the patient safety partner who Debbie and I have met with and is joining us in November, and also the patient safety representatives, which are 2 members of staff who have been appointed to these roles. And it's all part of the new patient safety implementation plan.
Okay, everyone content? Thank you very much. Thanks, Sally. So we could executive report item 7.
Yes.
Julian, just questions or?
Yeah, I mean, I think it's self-explanatory. The one that's, because some of the things are familiar ground, or you know, in the case of the CQC, just straightforward. I think the one that's worth highlighting is the work going on as a consequence of the review of Nottinghamshire and the implications for that, Martin. So in particular, in layperson's terms, they're talking about people with severe mental illness that's amenable to treatment, medication as well as others. And there's been a number of these cases over the years. The the seminal one was in the late 1990s, the Ritchie report into Christopher Clunas, which has parallels, 20 odd years later. In the early 2000s, things called an assertive outreach teams were established, which came from North Birmingham, and were designed specifically for cases where people had severe mental illness, potentially amenable to treatment, but potentially sort of quite chaotic lifestyles, and required teams with very small caseloads who are actually tracking people down, so very intensive. During the austerity years, most of those teams got folded into generic community mental health teams across the country, and is inevitably now there's a question mark again about the small number of people who are in our care, and about how well organised we are in the current state. I think it's very timely because there's no doubt about it, in the sense they are people we can make a difference for, but require significant intensity of resources, which are not always there. It also poses challenge, Martin, in areas, say, for example, it's maybe a little easier to establish just a team in Slough with a high density, perhaps of psychosis, and a small geographical area. It's always been much more difficult to think about what the right model of care is in West Berkshire, which is half the geographical area of Berkshire, and mainly an area of outstanding natural beauty. So I think it's things like that that we've laid out here over the coming months. Debbie and Tamina will be sort of keeping us posted on. My guess is that if we're honest about it, we'll need to rethink about how we look after this and care for this group of patients, and that will be a national consideration. I think the real challenge will be is how you do this across such a mixed environment like Berkshire. Much easier in inner city areas to do this. So I think quite a big piece of work, Martin, over the next sort of 12 months, where we'll be working with stakeholders, and one where we'll be needing to keep the board abreast, because quite understandably there'll be quite a lot of scrutiny, attention paid to this.
Thank you, Julian. Well, I can see it's going to need some thinking about. It's a difficult problem, isn't it? I just wondered, do we have an idea, just for the NEDs really, of how many people might fall under this service? This a sort of a more assertive thing across Berkshire.
Yeah, so you're extrapolating people with severe mental illness, and then because some people that are willing in terms of their kind of treatment, there has been previously in terms of the assertive outreach, but the numbers are quite difficult to predict. So when we last did this, I can tell you that the numbers didn't sort of compute, particularly in some of the sort of market town areas compared to Reading and Slough. So again, perhaps it will, as a result of our audit, Martin, which I know is in train, it might be better if we come back on that at a later date, rather than guess or give a number that's an academic number that just hasn't washed through. So
no, that's fine.
Part of the task now is for us actually to undertake this exercise, Martin, to actually look at that case by case, what's going on in the caseload.
Yeah,
that's okay.
No, of course, that's fine. I understand it'll take a while to get to the bottom of this and to work out and to indeed listen to the lessons learned. Naomi.
Yeah, Julian, I got the impression from your narrative there that our intention is to take this piece of work on trust specific. Is that right, or is our intention to reach out more broadly to Bob, for example, to for those resources to be deployed at the same time? I know there are pros and cons to both approaches, but just interested.
Yeah, a bit of everything really. This is a nationally high-profile issue, so there's a kind of national submission. There'll be some learning nationally, and we're definitely going to be working with Oxford Health on this, particularly as part of our provider collaborative, and again sharing experiences. So Oxford City, Slough, Reading, quite similar, but also they've got Buckinghamshire and other those kind of market towns, which is quite similar about how we kind of think about that provision in the future. So it'll be a national sort of regional stuff as well as then thinking about Berkshire. So no, it's at every level, I think.
Thanks.
Thank you, Sally.
One of the issues we discussed at the Quality Committee in the context of this case was that we're going through our sort of process of risk assessment, because one of the concerns was around the risk assessment, wasn't it, Julian? And a sort of risk to self and risk to others, as we ourselves review our own approach to risk, and whether there's any lessons learned. I know that wasn't the only, but I thought at the time it was pertinent to us, given that we're in this constant, this review of our own approach.
Yeah. I mean, I guess sometimes risk always comes up, but I think obviously this review was more critical because, as we know, the antecedent behaviour of the individual was quite alarming, with quite a number of kind of recent assaults which appeared to be kind of illness driven. So there was a clear pattern of kind of serious incidents that had come to the attention of various agencies in the police, mental health services, etc., housing, and family members as well. Again, I think you all know it, Sally, for the Clunis report, very similar hallmarks to that.
Oh, absolutely, yeah, absolutely. And I would say, in some senses, people are saying now, should we re-establish the assertive outreach? As you mentioned.
Yeah, well, it'll be some kind of. We'll be taking some bits of that, won't we?
Yeah.
But obviously, Debbie, Tamina, Minu will now be sort of working through this and working with sort of colleagues, as Naomi indicated, really. So I think quite a big piece of work, quite rightly, scrutiny and I think quite rightly a bit of broad scrutiny. I mean, the upside to this that I am positive about is these cases are treatable. They're more straightforward than some of the other cases that we have. There's a good evidence base that paranoid schizophrenia now, the combination of evidence-based treatments are very effective. And so, whatever we're doing, if we deploy our resources, we can really make a difference for this population. They often get squeezed out. And that's one of the issues, because they're not coming forward and demanding the kind of care. So a much more nuanced, thoughtful approach is going to be required. A bit of a reset, I think.
Okay, thanks so much. Well, we look forward to, obviously, we'll be having discussions about the report and the findings and what your plans are in due course. Rebecca, welcome. We're just doing the executive report, item 7. So, yeah.
Thank you. Yeah, apologies.
That's all right. Understood. Thanks for joining. Okay, anything else on Julian's report? All right, thanks so much. So thanks for that, Julian. Some important issues there. Finance, Paul.
Thanks, Martin. So reports in the papers, was relatively straightforward. Generally, I think we are in good position financially, so we're still reporting that we're delivering our plan for the year. So at July, we posted a 800,000 surplus, which was 100,000 ahead of where we planned to be. We'll formally do a mid-year forecast over the next 6 weeks, but indications at the moment are we're still on plan month 5 and still expecting to deliver our financial plan for the year. In terms of workforce, the numbers in the report don't include the agreed 5.5% national pay award. That's going to be paid in October, so it'll come through in the month 7 financial report. NHSC have confirmed that it's going to be funded, and we're expecting that they will apply an inflationary uplift to our contract values to cover the value of the pay award. So we'll see that come through, as I said, in October. Workforce-wise, we saw a small increase in workforce over the course of July, but I think you'll know we're still managing the workforce and the pay bill within the overall plan for the year. So we're 600,000 underspent this year, including our expenditure on temporary staffing. Coming on to temporary staffing, if you look at the values compared to last financial year, at this point we're spent 200,000 less than we did last year. So this seems to move monthly in terms of where we're seeing the under and overs. At the moment, we're slightly ahead of where we were last year on agency, but that's been offset at the moment by lower bank spend. So I think we're 100 up on agency and about 300 down on bank spend. We're maintaining agency usage within the 3.2% target for this year, currently at 2.8. And the team are doing sterling work in terms of trying to manage those agency shifts that we're booking off framework. And we're continuing to see a reduction in those numbers, and they really, really are quite small at the moment and not of any financial concern. In terms of non-play, seeing pressure on inpatient beds, which has meant that the level of out-of-area placements increased in July. Apologies, that there's a slight typo in the report. It should say that the average bed numbers have increased to 29 in July, opposed to I think 19. It says in the report. So we're 400 higher than we were at this point last year in terms of spend. But what we are seeing is specialist placements continue to be managed, and that's 600,000 lower than at this point last year. So overall, in terms of specialist and non-specialist placements, we're slightly better than we were at this point last year. Just move on to ERF. So this is the additional activity. Performing well for Bob. We're slightly behind where we want to be in Frimley, but I know the community services are reviewing that position, and to be fair, the position on activity against Frimley's plan has improved, so we're hoping that we'll be able to pull that back before the end of the year. CapEx spend so far this year is only 600, but we did back phase the plan, so that 600 spend is against a plan of 1 million. The majority of our big schemes, including West Reading consolidation and our major IT replacement programme, are phased in the latter part of this year and are expected to deliver on plan. In terms of our non-CDEL spend, so this is the spend relating to the PFIs, we've started the considerable programme of work at PPH around the anti-ligature toilet and bathroom replacements. So the 400,000, the plan that will be spent, it's just a timing issue on when we started. So there's a slight shortfall in plan at the moment relating to that. Cash, we're still in a healthy cash position with 52 million in the bank, which is slightly behind plan, and we're still just working through some issues with local authorities, just in terms of timing of payments and getting purchase orders agreed. So no risk in terms of our cash position. Happy to pause there and take any questions.
Thanks so much, Paul. Any questions? I've just got something, Paul, whilst people think, oh, Naomi.
Yeah, just to quickly put, I should know the answer to this, but I don't. So if we breach the 3% agency cap, what's the penalty?
Reputational. Reality is if we do it, if we manage it within our overall position, there's some mitigation there, but realistically it's reputational. We want to be below that number.
Gotcha. Thanks.
Okay, Paul, my question is about the usual one about staffing. If I look at page 64 or 5 of your, I think 64, the back, staff detail by division, and I look at the plan compared to either worked or contracted, in all the 3 clinical services, the total number worked is less than the plan, because it's falling away. Is that difference filled by agency, or is that difference just accepted as the plan was perhaps over-egging it?
I don't think the plan was over-egging it. I mean, I think we've worked really, really hard with our workforce colleagues over the past couple of years to bring those numbers down. So I think historically those gaps would have been much bigger. What we're seeing there is just the impact of being able to recruit to our planned numbers. So you think into that plan, we've built in our investments for this year around mental health, SDF, etc., which we've agreed with commissioners. Reality is we are short in some areas in terms of being able to recruit into those. It's challenging.
Okay.
So the contracted line, the blue one, just to be clear, that would include the bank, agency, and any additional hours that are worked by our staff. So that we're still below where we expected to be, which is why we've got an underspend on our pay position.
Okay. So the blue one to compare with the green line really is the two one needs to look at in terms of the overall ability to care for our patients, as it were. All right, thanks so much. Anything else for Paul? It looks very tightly managed, Paul, as it is, but the challenging times, isn't it? Particularly recruitment. Okay. Performance report. Tamina, I think, was going to do it, but I think she's unable to join us just yet. Paul, are you able just to speak to this?
I would just say take the report as read and pick up on any questions, Martin.
Okay. Anything on the performance report? Sally.
Paul, this is probably a question for Debbie, actually. Debbie, should I be concerned around the increase in falls, or is I know you would have delved into it, and it might be one patient, but you know what's the sort of narrative around that? Because it looks as though it's increased a wee bit, and I know we've done a lot of quality improvement work around falls.
Yeah, so I wouldn't worry on 1 month, because it will be to do with one patient. We should be looking over a period of time. So absolutely we wouldn't, but from an operational perspective, each one is looked at. Do we need to do anything differently? Do they need different care plans, etc.? But I was not worried. This is still really low compared to many organisations, and it's a real aspirational target, if you like, and 1 month
doesn't say much.
Doesn't say much. No, doesn't worry me.
Just one to look at in terms of how it progresses.
Yeah.
Thank you.
Rebecca.
I was just looking at the physical assaults on staff, and Rose Ward seems to be much higher than all of the other wards. Is that 13?
Yeah, there's a particular patient, Rebecca, that was causing some challenges on there, which is being obviously looked at. But yes, we do see from time to time, depending on patients in different wards, peaking compared to others. This month it was Rose Ward.
Okay, thank you.
And Debbie, I've just noticed that the health visiting, which I always keep going on about, has shown an improvement. It's gone up to quite high levels. Is that just recruitment of people, or is this any systematic issue underneath? Or
I don't know, if I'm really honest, Martin. That's probably one for Tamina, but I can look into it for you.
Well, it's all right. Well, I'll speak to Tamina outside the meeting. Anyway, it's a good movement in the right direction. Thank you very much for that. Okay, Naomi.
Sorry, Martin, just real quick before we just leave the performance scorecard. I just wanted to, this might be a question that just needs further thought or whatever, so it's a tricky one. So the clinically ready for discharge and the bed days occupied by patients who are ready for discharge. I absolutely fully appreciate that those targets are designed to ensure better outcomes. That's the ultimate objective, recognizing that people that spend too long in one place of care kind of inappropriately could face deterioration. So I absolutely appreciate that's the outcome, that's the target. So do we have any way of measuring that? Do you see what I mean? I know this is a relatively new measure, and one that absolutely feels right, and I'm sure there's plenty of evidence to suggest that we are measuring the right thing in terms of outcomes. But is there a way in which we can make sure that that is actually the case?
Martin, I feel like I've come at a really opportune moment. I'm so sorry that I'm late.
Oh, that's quite all right, Tamina. Over to you.
So is your question about whether there's actual harm when people are delayed in discharge? Was that the question you were asking, Naomi?
Yeah, I'm sure there is, and if there's a way, I'm just so interested in ensuring that whenever we, when all our performance measures are properly arranged, are properly looking at what the outcomes are. Because it's so easy to lose sight of that. So I'm just gently pressing on that to ensure that we are thinking about, we're always thinking about our performance measures from the perspective of patient outcomes. And
Sure.
you know, so it's a difficult one actually to even articulate, because because logic would dictate that just measuring those two measures, so when clinically ready for discharge and the number of bed days occupied once a patient is actually ready for discharge, logic would absolutely dictate that that's the right thing, because we don't want to keep patients too long in our care if they're ready to be moved. I guess I'm asking about whether or not we have the ability to determine that the outcomes that we're seeking, in other words, an improved outcome by measuring these things, is actually working.
Okay. From my perspective, and Min and Debbie might have a view as well, I suppose there's 2 or 3 things that sit underneath that measure. Part of it is about, I mean, objective, it's actually also about measuring flow, so it gives us an idea about where there are particular challenges with the next step in somebody's care or treatment. And we will find, for example, there are particular local authorities at various points have real challenges about expediting discharge. And of course, if we have someone occupying a bed that they don't need to occupy, there will be people who do need a bed that aren't able to access one. So there'll be an element of that as well. And of course, if we do need to find a bed for them, they're more likely then to go in and out of area placement, which we know is much less kind of appropriate than if we were able to manage them within our own acute setting. Whether we specifically look at the impact on those individual patients, I suspect we do. So I know when I talk to the team, they will say patient X or Y, actually they're ready to go. The issue with them still remaining in an inpatient setting is that the next stage of their treatment or care, which is, you know, managing the community, they're not able to facilitate, and you can sometimes get a deterioration in people if they stay too long. We also want people to recognise that an inpatient stay is a part of their treatment plan, and they will be discharged, so they don't identify an inpatient setting as being a place they should be staying for any specific length of time. It's a very different way in which we want to be managing the care that we're providing as well. But Minnie, you can probably give a better medical overview than me.
Not at all, not at all. I wouldn't put doctors about anything in this world, but thanks to Mina. So I think it's a very fair question, Naomi. The answer to that is I don't think anywhere there is a systematic way of collecting everything, you know, patient experience, patient outcomes for specifically the group of patients who are delayed discharges. However, there's plenty of literature on it. So the risks go like this. One is infection control. So if you have a hospital where you have large amounts of infection, the longer you keep them, the more likely they are to get an infection and actually have really poor outcomes as a result of that. We don't see that, but I can't absolutely give you the data because we don't systematically collect data only on that group, but we know our infection control is quite tight. The other is patient experience. Experience is always poorer if you're in hospital. I mean, I've spent a day or two in hospitals and I've been dying to go home, you know, during that time. So that's always a given. But there is this angle to it, and it is that the delayed discharge is not often as straightforward. It's often in discussion with the patient, the family, that there are certain requirements in the patient's home modification or future arrangements which are absolutely essential, and hence the discharge is delayed. And I think then there is a level of understanding on behalf of the patient and the families that this is better for the patient. This is just one side of the story I'm telling you. Tamina has told you the other side, which is, of course, you know, flow gets disrupted. You know, other patients may not benefit from local placement, etc. So I'm just trying to give you the whole picture. But I don't think anywhere there is a systematic way of collecting outcome measures based on delayed discharges. There might be, but I'm not aware.
Yeah, that's super helpful. And you got to the point which I was trying to articulate, but did it badly, which was where there are nuances for an individual patient and complexities that, and then I guess it comes down to communication to ensure, or to try and ensure, that the flow is optimized for those individuals. But thank you, that's helpful.
Thank you very much. Anything else? And Naomi, just the terms of reference changed for your committee, I think.
Yes, thank you,
8.2.
Martin. I think it's, sorry if I could just get to the right page. We decided to delete a clause which was no longer relevant, or in fact hasn't been relevant for some time, which relates to reviewing at least annually the credit rating and report on benchmarking of investments and borrowing activities since the date of the last review. So they're just not relevant to us. We don't borrow, we don't have a credit rating, so it seems superfluous. So it was logical to delete.
Okay, everyone happy with that? Thank you very much for that. Right, now on to strategy issues. Oh, so is it? No, that's it. The strategy issues. So workforce race equality standard report.
Thanks, Martin. I'll just introduce these. So we've got the workforce equality standard reports in public annually that we need to note here, therefore race and disability. Ash is here to just talk us through the highlights really, and I think we should take the papers as read, Ash, and if you could just pull out key themes, key issues. I think just in the context for the race equality standard, our anti-racism work is clear. We've got lots of work to do. That's shown in the race equality standard reporting here. There are some improvements. We may or may not expect things to deteriorate as we really get into the key issues driving perspectives on equality in race, but we are seeing some improvements again, some knockbacks, but overall some improvement, which is pleasing to see. I'll hand over to Ash just to take us through the key highlights and we can open to questions.
Thanks, Alex. Thanks, Martin. Yeah, just to add that, the data is at the end of March 2024. We are still awaiting data from the national team, so we can do some comparisons, as you'll see some gaps in there, and also to assess our race disparity ratio that looks at the likelihood of colleagues progressing up through the organisation. So that's last year's table you see there. So hopefully that will be coming out around sort of September, October time. But as Alex has said, overall we have seen positive change and improvement out of 6 of the 9 indicators. 3 have declined, although improvements have been made. Of course, we'd like to see those bigger improvements, but over a 3-4 year trend, overall results are positive. So we are moving in the right direction. But obviously, it's still not good enough that we have inequality and experience. And as Alex said, our anti-racism action plan is well underway to try and address these inequalities. In terms of indicator 1, our workforce has grown by 398, and our ethnically diverse representation has grown by 154, which is making up 39% of this growth in our workforce, compared with 61% of the growth being white. We still have 124 colleagues who haven't shared their ethnicity, although this is improving year on year. Same with the WUDES, but it's improved by 13 this year, so 13 more colleagues are sharing, and it's mainly clinical staff who aren't sharing their personal information. We're still underrepresented in our ethnically diverse staff groups by at least 10% in each of our bands 8A, 8B, C and 9. But as you'll be aware, we've got a recruitment work stream looking at that, and we've already introduced a couple of measures at 8B and upwards to improve there. In terms of the 3 that have declined, one is around the likelihood of ethnically diverse colleagues entering the disciplinary process, and that's declined from 1.21 to 2.43, although that has seen progress over the last few years. We did already have actions here as part of our anti-racism action plan, but we're starting with some training, obviously, later this month for all of our investigating officers, HR colleagues, and then we're moving into a casework review in the new year. So we've got actions well underway there. The second one was around likelihood of white staff accessing CPD compared to ethnically diverse staff, which essentially white colleagues are 1.55 times more likely to access. But again, we did a deep dive to look at this, and actually it's about how we get ethnically diverse colleagues accessing that CPD, because once they do apply, it is representative of the workforce and how those CPD funds are allocated out. It's just the first step, because we have a two-step approach there to CPD. And the third one is around the percentage of staff who experience discrimination at work from a manager or colleague. And that's just declined slightly from 13.2 to 13.3. And again, we've got actions well underway as part of our anti-racism work to change this experience, including things such as part of our appraisal is including questions around conversations around race. We've got violence prevention work going on and training as well. So that's the highlights of the res. Any?
Ash, may I just add on the casework issue? So we have reported into the board around our casework and noted the disproportionate impact on ethnically diverse staff. Just to assure the board, in terms of the nature of the casework, Jane Nicholson and team have looked at individual cases, and the nature of the issues requiring formal review should stand. The key issue for us and for the casework review is, if that had been a white member of staff, would the same action have happened? But on the face of it, the nature of the issues that needed to be investigated did require formal process. We're going to get into what's the comparative to if that had been a white member of staff in the casework review. Thanks.
Thank you. Any questions for Ash, please? Sally.
Ash, this is a sort of slightly left field question, and you possibly won't be able to answer it, but I've read recently a lot of work. I think NHS providers have done a lot of work around bank staff and agency staff that actually feel very discriminated against, or they don't feel psychologically safe. And it struck me when I was reading these reports that we don't actually, some of our bank staff are quite permanent, aren't they? And yet we don't actually collect data. And I realise why we don't collect data, because we're not asked to collect the data. But it just struck me where we sort of get those perspectives, because a lot of them are from ethnically diverse backgrounds, and yet it's sort of lost to us in a way. And that's why I say it's left field. I'm asking you something that actually none of us have thought about up until now, really, have we?
No, thanks, Sally. Yeah, interestingly, last year there was the bank res, so we did include data around the bank res, but this year it's been taken away. There is ongoing work engaging with our temporary workforce in terms of their experiences, and I know colleagues in the team are ongoing, looking at those experiences and particularly at PPH as well.
Right. Thank you,
Rebecca.
Thanks. Yeah, the report was really helpful in the way that you'd set out what the data's showing. So thank you for that. On the training, you'd mentioned CPD, but it also talks about non-mandatory training as well. Is there a distinction with how people apply? Because obviously the CPD is required. So I guess I'm assuming there's a different route for someone putting their hand up wanting to do some non-mandatory training. And is that being looked at in terms of any further disparity on the non-mandatory training side?
Yeah, it's a good question, Rebecca. We did do a deep dive last year, and we've got another one planned this year as well to look at this. And I think it's important to note that this is a framework that the NHS uses, and actually, some of the calculations that are used to work out these metrics are complex behind it. But what we can do is start to pull across that data in terms of because non-mandatory could mean accessing some of our e-learning packages that aren't mandatory, or it could mean accessing a university course that's funded. So yeah, we do need to delve into the data a little bit more to understand that better.
And in terms of some of the things that you're, as well as diving into the data, some of the things that you're looking at putting in place, could you just outline some of those? Because I'm just conscious that, not just in the NHS, but across a lot of professions, we know that certain groups just won't put themselves forward, and there's a confidence issue, and whether some of the work that we're doing sort of is factoring in almost needing to push people a little bit and encourage them and raise awareness for applying for these opportunities.
Yeah, absolutely. That there is always more we can do, but we've engaged with our staff network. So we've had sessions with our race equality network, outlining how the how our trainer needs analysis process works, how they can apply, how they can access, as well as we've looked at access to things like leadership development as well, in terms of and sharing that with our networks, being very open and transparent. We also produced a video around accessing CPD in development and coaching, and we're really pushing our coaching offer as well in the organisation around how people can have a coach to support in improving their confidence and that sort of thing as well. So there's several things happening, but there's always more we can do.
Yeah, because I think some of those things are sort of communication in a broad sense, so everybody is hearing that. But actually, I suppose the concern is that some people need, almost on an individual basis, to be told, you know, have you heard about this? Have you thought about it as part of whatever development plan, their appraisal or whatever? I don't know if that more granular support is being provided.
So Rebecca, in the next couple of weeks, I'll be profiling the opportunity around mid-year reviews and talent and career conversations, and that is exactly the place where, you know, review of the formal PDP that was set and opportunities like these to be discussed one-to-one with individuals for that encouragement, where there may be an issue either not around awareness of what might be needed or confidence. So it's that space at mid-year and at appraisal and PDP settings where these conversations need to happen. And because we've got the anti-racism work and awareness permeating now, hopefully through the organisation, then people are much more mindful that these conversations need to happen, because we can see this kind of data where we need to push on and encourage and build that confidence and create the opportunity fairly.
Great, thank you.
Thanks, Rebecca. Naomi.
Yeah, I just want to go back, if you don't mind, Alex, in particular, to the casework, the disciplinary process, and actually make a request that the review and the other piece of work that you described comes back to FIP. You'll recall that we did a review of the revised process when it came into being, whatever it was, 18 months, 2 years ago, which was very pleasing to see and resulted in the material shift in the metrics between 2021, 22 and the following year, and took us from being, frankly, an outlier as far as the average across NHS Trust is concerned, to being in the mix. And I know these are averages. So it is a bit surprising to see that there has been, a statistically identifiable shift in the wrong direction, in inverted commas. So I'm just sort of encouraging that review and asking that the insights that get developed from that come back to FIP so that we can have a good look.
Absolutely. Thanks, Naomi. We will do that.
Rebecca.
Yeah, just I guess following on from Naomi's point, just some of that review, I'm just wondering whether there's some analysis that can be done on whether, if you are working in a certain type of area of the trust, you are at higher risk, so to speak, of doing work where you're more likely to fall foul of procedures and end up being in a disciplinary process. Because I know that certain areas of the trust, we have higher proportion of ethnic minorities working, and if there's a correlation there between the type of work they're doing, is that they're almost higher risk of ending up, regardless of their characteristics. It's more the type of work that they're doing. I don't know the answer, but I'm just wondering if we could maybe do some of that.
You're spot on, Rebecca, and absolutely a sense of that happening in Prospect Park and our mental health inpatient wards, where we have a disproportionate ethnically diverse population of staff, and some of our highest risk, most unwell people, where issues are happening. So we will make sure that's segmented and really clear in terms of drivers. I know we've had an update on culture of care in the exec report, and Debbie, you might want to come in around the work there that's going to tune in with anti-racism work at Prospect Park, and could well be helpful.
it's quite early days to know exactly what that's going to look like at the moment. But the Culture of Care programme does have an element of anti-racism actually absolutely running through it as a thread, and it is looking at leadership management, restrictive practices, our risk assessment, and a whole cohort of metrics, tools, and ways of working. So I'm sure it will come into it. And I put my hand up for the same reason Rebecca say. We absolutely know we have a higher percentage of our staff entering formal processes at Prospect Park, and we have a much higher ratio of Black and ethnically diverse staff working at Prospect Park. So we need to do that comparison for those cohort as well as just comparing it across the whole organisation.
Yeah.
I think there's going to be some merits in really understanding that context of where care is being delivered and where issues happen and what's an alternative approach. And I think we've got some experience of that through other cases which we can start to think about in this analysis. Sorry, Rebecca, I talked over you.
No, sorry, I was just going to say, without it being a foregone conclusion, but I think there's a clear indicator there. That the next thing I suppose to consider is the training need, because ultimately, even if the stats show there is that correlation, I think the aim should still be that we'd want to shift that in the right direction. And so it's what is missing essentially that is causing those staff to end up in that position. So beyond the environment that they're in, is it that is it a training need or supervision or whatever that we can do something different to try and shift the needle?
Yeah, and I think the advice and support we put in the moment is really key in terms of our HR people partners, our investigating officers, and ASHA reference and training that we're doing. Pleased to note that Roger Klein is going to be working with the trust as one of the first trusts around his Too Hot to Handle report, and some specific training to support us understanding the nuances potentially we're going to need in these different work environments and in clinical care settings. So that's a specific action that's going to drive our support in the moment and ongoing through any investigation.
Yeah, that's great. Thank you. Yeah, because I guess it's that training that kind of makes it practical as opposed to, not a criticism of the online training that has to be done, but sometimes you sort of do that training and tick the box and it doesn't impact your day-to-day really. So this needs to be something that is really practical to deliver a change in the way that services are delivered.
Thank you very much, Rebecca. Naomi.
Yeah, I just want to endorse what Rebecca was saying. I mean, the objective here needs to go upstream of the disciplinary process, so that the likelihood of anybody entering the disciplinary process gets risk managed. You de-risk that, and it sounds to me like that's the direction of travel. And I just wanted to make sure that that's the emphasis, because I have a strong sense that the process itself is reasonably robust and working, and we've had sufficient time to test it, and et cetera. So, but let's make sure of that as well. So,
and my reference to investigating officers is really at that early resolution stage, which is where we did get really positive impact, as you've noted, Naomi, over a couple of years. So has been disappointing to see that bump back up. So it's what's caused that change, and we got a trend we need to really get into. So thank you. Really helpful.
Thanks.
Okay, thank you very much. Ash, thanks for all the work you're doing. This is a really important issue for the trust, and I know there's been some sort of progress and a lot of hard work behind that. I do echo both Rebecca and Naomi's comments about understanding why these particular groups, is there something about the way we deploy them, or the environment they're in, or something, to understand that bigger picture. And also, I think particularly Rebecca's point about training, that I always get slightly nervous when we hear about we're going to put more training around, but it has to be training that, is focused on some practical, real issues that need to be explained and exposed, rather than just general training. But you're the expert and I'm not, so But thank you for what you're doing. It's really important work, and a little bit of progress. Let's hope we can keep going and unpick some of these more difficult challenges. So could we move on to WDES?
Yeah, of course. Yeah, thank you, Martin. Same again. The data is at end of March 2024. We've seen mixed results this year with 4 of the 13 metrics declining, 5 improving, and 3 staying the same. The areas that need more focus on, if you like, are the indicator 1, the disclosure rates on ESR, particularly for medical colleagues. Although a QI approach, we've uncovered that we have been capturing this data for medical colleagues, but not actually getting it onto ESR. So we've got plans in place to rectify that there. So hopefully next year we should see a bit of a change there. Inclusive recruitment, as likelihood of shortlisting has slipped this year ever so slightly. But it used to be more likely to be appointed in our organisation if you were a disabled colleague. That's just slipped ever so slightly this year. But again, you know, we've got ongoing recruitment work, and we'll be having that intersectional lens to see what may have gone on there as well. Encouraging and improving the reporting of harassment, abuse, and bullying as a 0.5% decline there, another slight decline, and it's just understanding that the reasons why people are not reporting, and some work around perceptions around opportunities for career progression as well as slipped slightly. So again, sort of links in with the res in the CPD and access to non-mandatory training there as well. And the last one was around our casework approach as well, and processes for disciplinaries. And as we've just talked about, we've got plans to look at that. In terms of our disabled workforce, we've increased by 60 this year. As I say, a large number of the workforce, 389, who've not shared their disability status. So the caveat here is that, you know, that's a good chunk of the workforce that could impact some of those metrics if they were to share. Similarly to the res, we are most underrepresented in bands 8C to VSM. But equally, is to note, this is the highest group of staff who haven't shared their disability status. Again, so that could change things for us there. What we found as well with WDES is the feedback from our Purple staff network members aligns with the results, as they've just recently gathered feedback into developing their network action plan. So we'll be working very closely with them to see what we can do jointly in terms of actions against the WDES here. But that's a very quick rundown.
Any questions, please? Rebecca.
Just on the gap between the data that we do have, but it hasn't made its way onto the system, because some of those stats were quite high. I think they were like sort of 80-90% not disclosed in for some of the bands. What, just roughly speaking, do you know what that would take it down to? Or, I mean, you may not know off the top of your head, Ash. But...
No, probably not. No, it all depends, really. Yeah, I would say out loud, I think it's around 50% of our medical workforce haven't declared. So the big chunk of our workforce is in the medical space. So I think we might be able to get some early indicators once that work starts in the next few weeks in terms of trying to get that onto ESR.
Okay, and in terms of the reason, because I think, you know, some people don't disclose, they're not quite sure how the data is going to be used. And actually, personally, I had several attempts to get my data on the system, and I had someone else assist me, and then it still wasn't recorded, even though the person assisting me had done what they, you know, pressed their buttons. So I think there is some work maybe to look at around the way we're capturing that data, because I was very willing and very determined to make sure it was correctly captured. So for someone who is perhaps not so engaged in that process, it is maybe over ambitious to expect that people are going to record their data if we don't make it easy for them to do that.
Yeah, absolutely. It's a really good point, and we've got that exact feedback from our colleagues, particularly in our Purple network, that it's it's difficult to try and record.
So is there something in train to try and look at addressing that?
I mean, ESR is the system that we've currently got. In terms of whether we can do something like we're doing with our medical workforce, where it's been completed on paper but not uploaded, there might be something around that we could do. We've got some engagement coming up with our Purple network in terms of how we do that. The other issue, just to mention though, is that our neurodivergent colleagues, that there isn't space on ESR to record that. So we might find that a lot of those are those people that aren't sharing. But I think it is ongoing kind of support. We have been kind of putting regular communications out to the whole organisation around our ESR team can support, can sit with you, just as you've done. But it's a not helpful system in some respects.
We will take this away, Rebecca, to see if there is an easier way that helps and encourages staff to declare.
Yeah, and I guess the other point was, again, it's the same sort of thing. So I'm conscious there are many messages that get put out across the trust, and some of those can be missed, just not because not everybody's absorbing all of that information. Is it also for these key things, are they filtered down almost like a through the family tree, so to speak? So rather than just at the highest level of this is communication to all staff, does it that when you're so not just at the onboarding stage when it's flagged, but later on in your career journey, is there someone that has that conversation with you to say, this is the importance of collecting the data, this is what it's used for, not necessarily have you completed it, but more in a localized setting?
Yeah, I don't think there's anything as robust as you've mentioned. What we have done is used a variety of kind of communication modes. So, for example, I've been to engage with all of our medical colleagues, talk to them about why sharing is important, what we do with that data, that sort of thing. Like I said, we've gone to our staff networks. We've got new managers communication pack where it just goes to all of our managers in terms of how they can share things with their team. So we use several modes, but I think there is potential where we can embed that a little bit further locally.
Thank you.
Hey, Sally.
I'll make a comment and then it's a question. The comment refers to something you've just said, Ash, and I recall reading recently that colleagues with neurodiversity don't always see themselves disabled and are therefore reluctant, which I thought was quite thought-provoking. But my question was, it always strikes me with the NHS, we have to present under these strict categories, and to what extent behind the scene we as a trust look at the intersectionality, because even within ethnicity there's differences then, aren't there? But then when you look at sort of the different characteristics and they come together, do we do any analysis of that sort?
So for example, we've got our pay gaps. Is that the type of data you're thinking about?
You might get, say, certain ethnicities combined with certain sexual orientation will be more discriminated against than, say, one particular ethnicity on its own. It's that sort of interrelationship, which I'm not an expert in this area, but my reading of the literature is that's where you get the real differences. It's not just the separate categories, as it were.
No, absolutely, and where possible, we do want that kind of intersectional lens on things, because the social identities, when they come together, they do amplify the problem. We know that's in the data, the evidence, the research. So as we move forwards, that is how we would like to work, and there's no reason why we couldn't, these reports start to include that. We're just going off the national framework here with these documents. But like the pay gaps, we've done it in the pay gaps, and that there amplifies the pay gap across those with many protected characteristics.
So it's sort of something we're working towards, as it were.
Yes.
Thank you.
Yeah.
Minu.
Thanks. Ash, I just wanted to clarify and understand better. So I know you sort of mentioned earlier that the largest chunk of non-reporters, which increases the non-reporting percentage in the trust, is among medical staff. And I just wanted to understand. So within the group of medical staff, of course, the percentage is high, and I can propose a number of reasons, but that's not for today. But given that when we add up all the medical, the junior doctors, the dental staff, we are no more than 200 in the trust, we wouldn't be the group which would skew the trust results from 5,500 staff. So I just wanted to see, because we're keeping on comparing medical staff in all the categories. Within their own category, of course, they're high numbers not declaring, but within the trust category, what sort of percentage are we forming that we're using that as a reference point?
I don't think I've got a percentage figure for medics that haven't declared over the whole organisational picture, but in terms of staff not declaring, it's 7.5% as an overall of the workforce. So quite a big number. So that's 300 and I think it's 389. And of those medics, I think it was 109. So it was a big chunk. So you can kind of see the split there.
Yes, yeah, absolutely. In relative terms, of course, they are a largest non-disclosure. And if there were reason to propose, I think one of that, I think Sally alluded to it, is a definition of disability which remains vague. Sometimes when I'm asked, I sort of have to think twice, and then the default. And if you're a medical staff, you will have to be absolutely sure that you meet every definition because of all sorts of regulatory anxieties that medical staff have. We would never tick the box of disability. And I'm not saying others would tick it more readily. And then, of course, there are all sorts of connotations of medical staff declaring a disability without the confidence that no one else in the world will be able to view this data. I think the reasons are more subtle. You may never get that through any QI project, but you'd have to probably get it through a focus group of doctors who might be able to tell you why they do not want to declare that. But that's just my view.
Thanks, Millie. As I say, I think we have got a lot of the medical data, so hopefully next year it should change. But you're absolutely right, and of course we've got these people who just don't want to share, and you know we've got to respect that as well.
Okay, well, good discussion, Ash. Thank you again for all you're doing and your team. And there's clearly challenges still to be addressed, but we feel confident about the direction of travel. But I think some of this focus, again, understanding the detail, what's really underneath it, it seems to me important, such as the neurodiversity issues or such like. But anyway, thank you very much. We look forward to the next update.
Thank you.
Thank you very much. Can we move on to Audit Committee? Rajiv, anything you want to tell us?
Thanks, Martin. Yeah, happy to take the paper as read. I think as well as the standard agenda this month, we had a presentation with Mark around the AI strategy, and we also welcomed the new Ernst & Young audit partner after their partner rotation. So happy to take any questions.
Okay, any questions for Rajiv? Did you come to any conclusions about AI?
I think the conclusion on AI generally in the industry is people are probably overestimating the impact in the short term, but significantly underestimating the impact in the medium to long term.
Yeah. Okay. It'd be interesting to see how Aileen's going to tell us the answer. Aileen.
No, the only thing I was going to say, given the potential impact and everything, is that something that we should actually think about including as a relatively regular update, if not frequent, to the whole board.
Okay, I think we've got one of our discurses. We're going to be talking about digital, so it might be maybe we can have a fuller discussion there, educate ourselves, at least those that need educating like me. Okay, all right. Thanks so much for that then. Governor's update. I've got nothing unless Julie's going to remind me of something. Julie, have I missed something?
No, I don't think so. No, because of course it's we haven't had a meeting. I had the July meeting, didn't we? We had the joint meeting. Yeah.
Okay. I did have a chance to briefly meet some of the league governors across Bob at Brian Wilson, our league governor, invited me to do. So that was part of just spreading good news, as it were. Any other business? Okay, date for next meeting is the 12th of November 24. How the years fly by. Oh, Julian.
Yeah, just to say that we announced today across the organisation about Minu's retirement. We'll have plenty of time to say goodbye to him, so it's not a goodbye, but we should sort of formally acknowledge that Minu's tendered his resignation. And I think, Minu, is your last day the March Public Board, or have you actually done it so you miss the March Public Board? I can't quite remember.
I have planned it only according to my birthday. The first working day after the birthday, I am working. So I really have no idea about the alignment of the board. It's 10th of March is my last working day, which is a Monday. I may have just missed the board on the 11th of March if that was the case. But I shall watch it on our broadcast channel, the board recording at some point.
Thanks, Melissa. So February will be Minu's last board, and myself and Martin, you might not know it yet, are meeting recruitment agency along with Jane for the start of a national recruitment campaign that begins today, because we've got plenty of time to be able to do that, and myself and Martin are catching up on Monday to start to flesh that out. So huge thank you to Minu, but sorry, go on.
Thank you very much for that, Julian. I mean, Minu's going to be a very hard act to follow, genuinely, and so it's going to be quite tough finding someone of the right calibre. And I know Minu's very modest, but he knows it's true. So we'll have plenty of time to thank him for his support of the trust in due course, and we just need to make sure he works really hard between now and the next spring.
There's plenty to do, and it's going well so far.
Thanks very much, Julian. Okay, shall we take a break? What is it now? 11:40, 12 o'clock start?